Morning, everyone. I'll be presenting on behalf of Medicine 5. I have two cases. The first case is a 65-year-old lady who came to us with fever for 2 days. The fever was high grade and associated with chills and rigors. It was associated with vomiting postprandial and associated with nausea. There were no other localizing features for the fever. 2 months ago, she had anuria for 2 days, which was painful, and after which she was catheterized outside. And since then, she has been on a continuous bladder drainage. And after that, she was passing urine well through the CBD. Her comorbidity, she's a type 2 diabetic, systemic hypertension. She is also known hypothyroidism, and also had a recent right plantar abscess for which she underwent incision and drainage, and multiple admissions for urine infection treated with IV antibiotics. On examination, she was noted to be tachycardic, 128 per minute, BP of 110/60 with warm peripheries, and a respiratory rate of 28 per minute, and a temperature of 104 degrees. There was no pallor, icterus, clubbing, or cyanosis, lymphadenopathy, or pedal edema, and her right foot had a healed ulcer on the plantar aspect. Systemic examination, the respiratory cardiovascular system examination was normal. There was no renal angle tenderness noted in the abdominal examination, and the CNS examination was also non-contribution. Summarizing, a 65-year-old lady with comorbidities of diabetes, hypertension, hypothyroidism, and a prolonged catheterization on continuous bladder drainage came to us with fever, high grade with chills and rigors, and vomiting. Second is a 70-year-old male who came to us with fever for 2 days, high grade with chills and rigors, with decreased responsiveness since the last 2 days associated with the fever spikes, and he regains consciousness after the fever spike settles. And he also did not have any focus of infection, he did not have any vomiting, he did not have any dysuria, he did not have complaints of abdominal pain, flank pain. He's a known diabetic for the past 20 years on Mixad 2410, hypertensive also for the past 20 years. He was diagnosed to have Parkinson's disease outside, and he had undergone a coronary angiogram 5 years ago for an ischemic heart disease. And in January of this year, he was admitted for bilateral necrotizing fasciitis, and since then he was on a catheter for a period of about 2 months. On examination, his vitals pulse was 96 beats per minute, BP of 130/90, respiratory rate of 24, and he was febrile with the fever of 101 degrees. And on general examination, there was no pallor, icterus, clubbing, sinus, lymphadenopathy, or pedal edema. But on his both feet, he had fasciotomy scars were seen, and the wounds were dry and healthy. On systemic examination, respiratory and cardiovascular system examination was normal. Abdomen was soft, non-tender. There's no renal angle tenderness noticed in this gentleman as well. This CNS examination showed an expressionless facies with a restricted upward gaze with no tremors, but a bilateral symmetric left-right rigidity. He was moving all four limbs, and bilateral ankle reflexes were absent. There was neck stiffness in both in all regions, in anteroposterior and also side-to-side region. So, summarizing, a 70-year-old gentleman, diabetic, hypertensive, with a probable Parkinson plus syndrome, with again a history of prolonged catheterization, presenting with fever, high grade chills and rigors, with a hypoactive delirium with the spikes of fever. So, clinical diagnosis for both these patients. The first patient, in view of the fever, chills, and vomiting, and prolonged catheterization, and also antibiotic exposure outside, our first differential was a catheter-associated urinary tract infection. Similarly, for the second gentleman as well, there was fever, chills, hypoactive delirium with fever, prolonged catheterization, and antibiotic exposure. So our first differential was a catheter-associated urinary tract infection. So I'll just move on to the investigations here. So for the relevant investigations, the first patient, the lady, she had the urine routine of 128 pustules with a total count of 17,700 with a neutrophil predominant WBCs. She also had a acute kidney injury. She was a poorly controlled diabetic, and her ultrasound abdomen had shown a left kidney measuring 9.4 with a hypoechoic area, with the largest one measuring 1.5 into 1.6 centimeter in the lower pole, representing a probable evolving abscess. Moving on to the second gentleman, his urine routine was not was not very contributory. His WBC count was also 5,700, but with the neutrophil predominance. He was also a poorly controlled diabetic, and he did not have any acute kidney injury. However, his ultrasound abdomen in the right kidney showed an ill-defined hypoechoic lesion in the upper pole of the left kidney, measuring 14.7 into 11 mm, suggestive of a evolving renal abscess. So cultures were sent for these patients, and the first lady in her urine culture had a Klebsiella, which was carbapenem resistant, and the second gentleman had a blood culture showing a E. coli infection, which was also carbapenem resistant. On further characterization of the same, it is noted to have, both of them were noted to have OXA48 detected, and there was intermediate sensitivity to colistin in the first patient, whereas the colistin was resistant in the second patient. So here I would like to mention about carbapenem resistant organisms, when to suspect, how to identify.
How was the urine culture sample? How was the sample collected?
So from the recatheterized sample.
And what about the blood culture for her?
Did not grow. Carbapenem resistant organisms. So when to suspect, how to identify, how to treat, and how to prevent the spread of carbapenem resistant organisms in the hospital setting. So when to suspect. So here I've taken a study which saw 351 patients. It was a case control study. So they took patients who had carbapenem resistant organisms and carbapenem susceptible organisms. The one main thing I wanted to highlight here was that in the exposures with the long hospital stay, ICU stay, central venous catheter, indwelling urinary catheter, mechanical ventilation, tracheostomy, all these are associated with increased susceptibility for a patient to develop a carbapenem resistant organism. And in both our patients, they had indwelling urinary catheters being present, which was a significant risk factor as seen here. And the other main thing is prior antibiotic exposure. As we can see here, the exposure to carbapenems is coming with the highest risk of developing carbapenem resistant organisms. That is what I want to highlight in this slide. So how to identify here, we can have a phenotypic or a genotypic test in order to identify the carbapenemases that are present in the bacteria. Here we have the Carba expert, which has a fast detection to differentiate to identify the mutations to show if they have a KPC, NDM, VIM, IMP, or a OXA48 mutation. So this is the Ambler classification of the carbapenemases, where the class A has a KPC and SME genes, and the class B has a NDM, the New Delhi metalloproteinase, the VIM and the IMP, and the class D has a oxacelinase gene. And moving on to quickly how to treat. So the KPC producing infections, they are susceptible to the combination drugs such as meropenem, vaborbactam, ceftazidime, avibactam, or imipenem, cilastin, and relebactam. Polymyxin can also be sensitive. We need to check for the MIC for the polymyxin, the colistin. The NDM and other metallo-beta lactamase producing infections can be treated with ceftazidime, avibactam in combination with aztreonab, as they have a synergism seen, or it can be treated with a cefiderocol as a monotherapy. And here also polymyxins can be used if they are susceptible. And then for the OXA48-like producing infections, the ceftazidime, avibactam, and polymyxin drugs can be used. So how to prevent? So this is the crux of what I wanted to share in this clinical meeting. So how to prevent the spread of CRO in the hospital setting, and how to be antibiotic stewards, good antibiotic stewards. So improper antibiotic selection or dosing or duration in a patient with bacterial infection can lead to either treatment failure from inadequate antibiotic efficacy, or it can cause a clinical cure with a CRO colonization. So a few things off the bat. First, the strongest risk factor as far as antibiotics is concerned in the emergence of CROs is the use of carbapenem, which can lead to carbapenem resistant organism colonization or infection. So what are two things that we can do? One is to do carbapenem sparing options for the treatment of ESBL enterobacteriaceae. So here there can be a combination therapy with aminoglycoside with beta-lactams, because beta-lactams alone, like peptides, though they have an in vitro susceptibility, the in vivo susceptibility is not good. So aminoglycoside with the beta-lactams can be used. However, this comes with the risk of the peptides has an in vitro susceptibility in the ES as far as ESBLs are concerned. However, the in vivo response is not.
For that, please look at the pre-publication of the
Merino
trial. So if our lab reports that it is susceptible to the penicillin tissue vector, you can go ahead and use it unless the patient is in the ICU or iron probes and
however, this comes with the risk of kidney injury that can be associated with the aminoglycoside. The other is a third generation cephalosporin that can be used along with the beta-lactam with the beta-lactamase inhibitor. Other non-carbapenem antibiotics that can be used are broader spectrum antibiotics such as tigecycline, IV fosfomycin, and newer beta-lactams such as cephalosporin and cephalosporin tazobactam or cephazidime avibactam. However, we will not be using these drugs upfront. Then cefamycin such as cefoxitin and cefotetan could be used. These drugs were from an American publication that were taken. The aminoglycosides, the other new drug is a temoxilin, which is beta-lactamase resistant penicillin. Ertapenem is another drug that can be used. It has the ESBLs of Pseudomonas and Acinetobacter are not well covered by that by ertapenem. So it has a narrower range as compared to the carbapenem such as meropenem. The other thing, when carbapenems are used to optimize the dosing and the duration of the carbapenem. So some of the ideas mentioned in order to optimize the dose and the duration of carbapenem are to optimize the dosage with a therapeutic drug monitoring, which can be done through methods such as immunoassay, chromatographic methods, or biosensors. The idea is to shorten but also adequately treat the infection so as to not enhance a carbapenem resistant organism. Then there are also newer softwares for dose optimizations, which based on the drug levels can tell us as to how long the treatment has to be continued. And the duration is a few studies that from the papers that I have mentioned, quoted below, show that an uncomplicated GNB bacteremia itself can be treated with a 7-day versus a 14-day with a non-inferiority with a 7-day trial, provided that the source reduction has been done and the patient is not currently septic. Then for post-op intra-abdominal infection, there have been operated. 8 days is shown to be non-inferior to the 15-day. So just to emphasize on the fact that the dosing and the duration of carbapenem can be optimized in order to prevent the emergence of CRO. So back to our patients. So the first patient was treated with a 3-week course of injection cephazidime avibactam, and on her OPD visit, when we saw her the last scan that was done, there was complete resolution of the renal abscess in comparison with the previous scan. It was not previously, there was not amenable to drainage. So that was not attempted. The second patient, injection cephazidime avibactam, was continued for 11 days. As patient had cleared the infection from the bloodstream and also was clinically improving, he was changed over to a oral minocycline medication 100 mg BD for a total of 4 weeks. He was afebrile and he was able to ambulate to the chair. And he was doing physio and he's yet to come back for follow-up.
Ahikam, can you please go back? Yeah. Was it reported susceptible to cephazidime avibactam in vitro?
The second patient, yes, sir. First one, they did not mention.
You have to ask them. I think they do it routinely, but they will release it.
What did we ask?
What did you mention here?
The second patient they had mentioned, so the first one did not.
No, but the ceftazidime, maybe they'll do it separately if you ask
And the
them.
dose of minocycline, is it 100 BD or 200 milligrams?
200 stats and 100 BD.
100 BD is the 200 is the loading dose, and then it's 100 BD for the.
Just check that. I remember this one.
So the CDC.
What did you do to the polycatheter? CBD for both patients?
So we tried to remove for the first lady, we gave a trial of voiding, and her post-void residue was 31 ml. We'd planned to keep her under follow-up with the urology department. Gynecological examination, we did look for any other local.
So she went home without the CBD?
She went home without the CBD, but the gentleman we could not remove. We removed the catheter. He again had a PVR of 500 ml. And so we had to recatheterize him with the silicone catheter. So the CDC defines antibiotic stewardship as the effort to measure and improve how antibiotics are prescribed by the clinicians and used by the patients. So improving antibiotic prescribing and use is critical to effectively treat infections, protect the patients from harms caused by unnecessary antibiotic use, and also to combat antibiotic resistance.
Anyone have any other questions? You have a question, Tony?
The value of urinalysis in diagnosing catheter associated UTI. Is there any value to it? You yourself, your second patient did not have it. So either to rule in or rule out, it is of no value. So somebody has a long-term indwelling polycatheter, has fever, there is no other source. Most likely it's a UTI, and both patients have renal abscess also. You don't have to do a urine analysis. It doesn't help. Anybody who has a long-term indwelling polycatheter will have some. And like you said, when you send a urine culture, make sure that you don't send it from the collection bag, don't send it from the already present catheter, remove it, and the accepted precaution, recatheter, and then send it first. What is the mortality in your series, these patients?
So the ones who had Klebsiella had a higher mortality. Only Klebsiella, which we isolated from there, was around 50, no, sir, 56%.
56.
The ones who had only E. coli were about 49%.
So,
the first lady actually had septic shock and then went to the ICU and then came out.
So 55% mortality.
But she was in bacteremic, no?
She did not blood culture, did, but
second patient is bacteremic. Thanks, Ahikam.
So even if you do a GABA and it's only OXA 48, please look at also the in vitro susceptibility. Remember, we are checking only for APC, MBM, and OXA. Okay. There are other little attenuations. The lab reports it is susceptible in vitro, confidence in using these combinations.
Thank you. Today's presentation was